Greetings. Let us learn about gastrointestinal varices, uh, classification, anatomy, supply, and drainage of the varices. This is important when you want to manage a patient with gastrointestinal varices. These are my acknowledgements. Please read the notice. And gastrointestinal varices develop in a patient with portal hypertension, either because the liver has a problem or the portal venous drainage has a problem. When the pressure in the portal system increases, the blood tries to find its way from the splanchnic circuit to the systemic circuit using different anastomotic channels. And these anastomotic channels can present as esophageal varices that are typically seen in the mid to distal esophagus. And these are located predominantly in the submucosa and extend into the mucosa. And because they are in the mucosa, they are amenable to endoscopic therapy, either sclerotherapy or band ligation. Gastroesophageal varices 1 or GOV1 varices. These are esophageal varices that extend along the lesser curve of the stomach. When you find esophageal varices and you note the extent of the varices, whether going into the stomach, and if you find varices along the lesser curve of the stomach, then you label them as gastroesophageal varices 1. These are managed similar to esophageal varices with either banding or sclerotherapy. Gastroesophageal varices 2 or GOV2. These are varices that start in the esophagus and extend along the greater curve into the fundus of the stomach. And depending upon how big they are, they may need either banding or some form of glue injection. Next, isolated gastric varices 1. These are located in the fundus of the stomach. These are predominantly submucosal varices. Banding does not work. These patients require glue injection or some form of embolization by the interventional radiologist. And one could also consider TIPS procedure, that is transjugular intrahepatic portovenous shunt to decrease the pressure. Isolated gastric varices 2. These are these are located in the stomach, but not in the fundus of the stomach. They may be located in any place other than the fundus of the stomach. Could be in the antrum. These rarely bleed. And one could also find varices in places other than the esophagus and stomach. These are known as ectopic varices. Could be in the duodenum when they are called duodenal varices, or in the rectum when they are called rectal varices. And one could also find ectopic varices whenever you create an ostomy. surgical ostomies can develop ectopic varices. I hope this is useful, and learning this classification is important. And let us now go to esophageal varices. We will learn about the supply and drainage of esophageal varices. Esophageal varices are located in the mid to distal esophagus. As you can see here, they start at the GE junction and go up the esophagus. They're more prominent in the distal esophagus. Mid esophagus, they become less prominent, and they're rarely seen in the upper esophagus. And with portal hypertension in cirrhosis, blood flow reverses from the liver, goes via the portal vein, left gastric vein, and feed the esophageal varices. From the esophageal varices, blood reaches the heart via the azygous venous system into the superior vena cava. How about gastroesophageal varices 1 or GOV1? We've learned that these varices start in the lesser curve of the stomach and go up into the esophagus. And the supply is from the portal vein, left gastric vein, into the varices. And the drainage is via the azygous vein into the heart via the superior vena cava. How about gastroesophageal varices 2? They are located in the greater curve of the stomach and extend into the esophagus. And these GOV2 varices have a little bit of a complicated supply. From the portal vein, left gastric vein, to the varices along the along the right side of the esophagus, and the blood supply to the varices in the fundus goes from the portal vein, splenic vein, posterior gastric vein, and into the fundus of the stomach. And the drainage is one via the azygous vein into the superior vena cava, and via the renal shunt, phrenic veins to the renal vein via the shunt into the IVC. So when you have varices that extend into the fundus, you have to think whether they have a shunt. And this is important from the point of managing variceal bleed in terms of options. We have three options for managing GOV2 varices. One, you could consider endoscopic glue injection. Banding doesn't work. If glue injection doesn't work, you could consider, depending upon whether they have a large shunt or not, either TIPS procedure or retrograde glue injection via the shunt. We will talk about it later. How about isolated gastric varices? Isolated gastric varices are present on the fundus of the stomach along the greater curve, as you can see here, and they are supplied from the portal vein via the splenic vein through the posterior gastric vein. That's one route. And another route is via the short gastric veins into the fundus. These fundic varices typically drain through phrenic veins into the renal shunt and from there into the IVC. So again, whenever you have large fundic varices, either isolated or GOV2 varices that are difficult to manage with endoscopic therapy, typically glue injection, you should consider other options, either reducing the pressure in the portal vein by doing a TIPS procedure or going from the inferior vena cava via the renal vein into the shunt and deploying different materials to clog off those fundic varices. I hope this anatomy lesson is useful. Learning this anatomy is critical for management of patients with variceal bleeding. And I want to thank authors of this beautiful uh, practice guidance statement from the American Association of Study for Liver Diseases. I would encourage you to read this article. Thank you.